started your timer, and here is your question. Right, so if you have read and understood considering a critical care scenario, kindly please tell me how would you manage this patient now?
I'll manage this patient using the ABC of CRISP protocol.
Yes.
Want to assure that patient airway is patent by calling the patient answer airway is patent. I want to really check the breathing and ventilation. Sure, patient is breathing by using inspection, perfusion, and auscultation. Then I want to ensure white blood cannulas to site IV line, and also take samples for full blood count, A and U, liver function test, arterial blood gas analysis. I want to request for chest X-ray ECG. I want to do serum lactate. I want to put patients on IV fluid crystalloid at maintenance dose. I want to nurse patients in at 45-degree head up. I want to give patients analgesics, and I give high flow oxygen at 10 liters per minute with a non-regular face mask. Hello?
Yes, I'm listening.
Yes, ma'am.
Can you tell me what might have caused sudden sharp chest pain in the patient, and what would be your primary and differential diagnosis?
The cause could have been injury to the pleura.
Okay.
With likely pneumothorax or tension pneumothorax.
Okay.
Yeah. So if there's pneumothorax, I want to put do tube thoracostomy. If there's tension pneumothorax, I want to first do a needle thoracostomy at fourth or fifth intercostal space anterior to mid axillary line, then followed by tube thoracostomy.
All right. Can you please tell me what are the different types of pneumothorax that you know of?
Simple pneumothorax, tension pneumothorax could be open or closed pneumothorax.
Okay, what are the difference between tension pneumothorax and simple pneumothorax?
In tension pneumothorax, there is a mediastinal shift to the contralateral side. There's also tracheal deviation to the contralateral side. There's inflow of air into the pleural space, one valve inflow of air to the pleural space, and the patient is hemodynamically unstable.
Okay, can you please tell me what you understand by the safe triangle of safe triangle?
Safe triangle is bounded. The apex is at the axilla. Anteriorly is the medial border of pectoralis major. Posteriorly is the mid axillary line, and inferiorly is an imaginary line that draws across the nipple.
Okay, can you, because in this patient, central line was inserted, can you name few indications in which central line should be inserted?
Patients that require fluid resuscitation or adequate monitoring on fluid therapy. Patient that requires total parenteral nutrition there's need for invasive central venous pressure monitoring. It can be used for injection of certain fluid and injections to central line.
Can you please tell me or name few complications which can be caused because of the central line insertion?
It could be tube related.
Okay.
Tube related could either be failure. It could be migration of the tube. It
If
could
you
be,
can broadly classify it, immediate complications and late complications, then can you please?
Okay. Okay, ma'am. Immediate complication and late complication. For immediate, it could be there could be hemorrhage. If there is injury to the surrounding vessels.
Yes.
There could be pneumothorax. If there is a puncture of the pleural cavity.
Yes.
There could be hemothorax. If there is bleeding to the pleural cavity as well. Then there could be pneumonitis, there could be mediastinitis, those are these complications, and there could be surgical site infection.
Yes. All right. One of the worst one is air embolism. Okay. Can you please tell me what is the technique according to the NHS guidelines for the insertion of central line?
Seldinger technique.
Yes, please. Technique, please.
Okay. The technique is to identify the landmark, which is the mastoid process, the two ends of the sternocleidomastoid muscle.
Yes.
A depression.
What would be the position of the patient?
Patient has to be in
Trendelenburg position.
Trendelenburg position. Trendelenburg position. Yes, ma'am.
Yes. Then you have identified
with the head facing the contralateral side.
Yes. And then after you have located, yes, then
after locating the point, we want to I want to feel for the carotid pulse position. Now I'm doing the interjugular venous cut down. So I want to locate the carotid pulse. Then lateral to it, I'll direct my needle at about 30 degrees to the skin and pointing towards the ipsilateral nipple.
Yes.
Then gradually going and aspirating. Once I have blood in the chamber, then I cannulate the central line using the Seldinger technique. Then afterwards, I suture the cannula to the skin and apply dressing over it. Then give patient instruction.
Okay.
I also like to do, and this should be done under outside guidance at the same time they need to do X-ray following the procedure to check for pneumothorax.
Yes. Okay. Can you name the technique, or can you tell me how should central line be removed according to the NHS guidelines?
Yes, ma'am. To remove central line, patient needs to be put in head down position to prevent air embolism.
Air embolism, right. Can you air embolism also there can be a reason or
what's ma'am?
Because of the organism, I wanted to ask you, what is the most commonly organisms which can cause infection because of the presence of central line?
Staphylococcus epidermidis.
Okay, very good. Right. Can you tell me what measures can you suggest to prevent central line infection?
Yes, ma'am. To prevent central line infection, I want to to wash my hands. Adequate washing of hands before the procedure. To put on a gown, sterile gown. Wear a surgical glove. Apply an adequate sterile drape.
Yes.
Sorry, before then, I want to properly prepare the skin using appropriate antiseptic solution. Then probably add to use an adequate sterile drape, and to carry out the procedure using the NHS
Yes, you
guideline.
can read those so that you can tell me very quickly. If you can please help me read this X-ray. What kind of image is this and what are you looking at? These arrows are showing you something.
This is AP, anterior posterior chest X-ray.
Yes. Is it
Showing
anterior posterior or posterior anterior?
sorry, is PA view, posterior
Yes.
anterior view.
Yes. Arrows are showing what, please?
The arrows are showing ribs fracture.
What else can you see?
I can also see
is there any tracheal
there's
deviation? Can you see any tracheal?
yes, there's midline,
So you
there's
have
midline
to-
shift, there's
Yes.
midline shift, and there's tracheal deviation to the left side.
Right.
Midline shift to the left,
Okay.
shift to the left, and
What's happening on the yes
the
lung view?
costophenic and
Yes.
cacophenic angle
Yes.
on the left side are obliterated because
Yes.
of the shifting of the mediastinum. Then there is
What? How would you comment on the exposure? Whenever like you have to read the X-ray, an exam always read it in, if you know, A, B, C, D, and E, right?
yes, no, yes, ma'am.
So
The
what is
exposure is
A?
not the exposure is not adequate.
Yes.
Yes, ma'am.
Is the exposure is adequate or not? What about, can you see the vertebral column? How would you comment on that?
I can see the vertebral column, but they are not so they
Because
are not
E
so
is
clear.
not just exposure, E is also about the bones and the soft tissue extras, right?
Yes, ma'am.
So, and the D is for the diaphragm. Can you see the diaphragm here?
I can't see the diaphragm on the left. Even
No.
on the right is not so
Gas
clear.
under the diaphragm you cannot see. So what has happened?
There is a shifting. There is the X-ray is not adequate.
And
I think there's tension pneumothorax.
yes.
The
So
right tension pneumothorax.
yes, but how would you comment on the size of the heart and the great vessels?
There's cardiomegaly.
Okay, what about the size of the great vessels? They are
also dilated.
distended. Very good. And would you say if there is any mediastinal shift or not?
Pardon?
Any mediastinal shift?
Yes, there's mediastinal shift. There's
All
mediastinal
right,
shift.
good.
Yes, ma'am.
What about the lung? Do you see it collapsed?
The lungs on the left side is actually collapsed. There's reduced lung tissue.
Yes.
Reduced to only the upper part.
Are there any effusion? Any effusion you could see?
It's difficult to say because of the position of the lung of the heart.
Yes.
But the cardiophenic and costophenic angle are actually obliterated. I can't see them.
Otherwise, you would be able to appreciate it. Okay, good. Thank you.